and TIP Transference Training, which is the focus of today's webinar, which is our advanced experiential training for therapists and practitioners who want to deepen their capacity to work directly with transference dynamics in the therapeutic relationship. Slide. So this training takes place in person this fall from Wednesday, October 21st to Sunday, October 25th, and that's followed by 5 months of virtual learning. And some quick housekeeping. If you have any questions that come up during this webinar, we ask you to just hold it till the end. We'll have a thorough Q&A segment and you can ask it then. So please just keep that question in mind till the end. Slide. So we want to share with you a quote from a past participant, Pierre Bouchard, who's a current therapist, and he had this to say about the TIP Transference Training. This course deepened my understanding of transference significantly and gave me a way to work with it that has been a dynamic game changer in my clinical work. I don't know of another training out there that offers this much potent material and practice regarding transference that is also in such a condensed time frame. I would recommend this to anyone who has studied the basics of trauma work and is wanting to go to much more nuanced places. Slide. So with that, I'm very happy to introduce our two presenters and trainers for the TIP Transference Training, Dr. Eric Wolterstorff and Dr. Herbert Grassmann. So Eric Wolterstorff is the developer of the Trauma Integration Protocol. He's also the author of the Trauma Integration Protocol Psychotherapy Training Manual, which I have a copy of right here. It's a beautiful colored paperback, and it's available through our website for those who are interested. He has designed and led trainings in TIP foundations, TIP transference, and psychosocial levels. Eric has a Ph.D. in group trauma dynamics and has trained with some of the major figures in the trauma and somatic fields, including Peter Levine, Pat Ogden, and Arnie Mindell. He has taught hundreds of psychotherapists in the United States, Germany, and Austria. And one of Eric's great gifts is his ability to take complex theory and translate it into practical therapeutic tools that clinicians can actually use. Slide. Herbert Grassmann, Ph.D., is a globally recognized trauma therapist, somatic educator, and author. He has designed and led polyvagal embodied and body-based psychotherapy trainings in the United States, Brazil, Germany, and Austria. He's the editor and co-author of Somatic-Oriented Therapies together with Stephen Porges. And I have his book right here. He has published on polyvagal theory, embodiment, trauma, body awareness, autonomic reactivity, and relationship in psychotherapy. Herbert brings rigor, embodied wisdom, and a deep sensitivity to the relational dimensions of trauma. Together, Eric and Herbert bring a rare combination of depth, precision, and humanity to this material. So with that, I'm very glad to turn it over to Eric and Herbert.
Thank you so much, Barzan. Hey, and it's nice to have you all here and to share something about the work with you. Before I step into what we're offering in this training and some of the concepts that are key to this approach, want to both acknowledge and share with you some of our lineage, right? So Peter Levine, through his modeling the autonomic nervous system and somatic experiencing, Stephen Porges with his polyvagal model of the autonomic nervous system, Ron Kurtz, who was the developer of Hakomi therapy, Murray Bowen, who was one of the great family systems therapists, Lloyd DeMoss, a lay psychoanalyst who has talked about how you use these psychogenic modes to relate, sort of taking Erik Erikson's work a step forward of how does individual capacity to empathize relate to how societies form, and in general, the psychoanalytic tradition around transference and countertransference. So in this presentation right now, I'm going to spend some time talking about what happens in a traumatic event and how that traumatic event is stored in our memory. And then I'm going to turn to what the implications of that are for psychological recovery and healing from traumatic events. And then thirdly, turn to what new skills or abilities do therapists need in order to help clients make that transition. So here we go. So the scene of the crimes is what Herbert and I like to call it. The idea is that when a trauma happens, we don't simply store the memory of what happened to us. We store the whole scene in kind of a shorthand way. So we've got a victim, the person that something bad happened to, the perpetrator, because we're talking about relational trauma, who acted against that person, and then if there was a savior present, and we'll talk later about how sort of bring the savior in later, even if they weren't there at the time. And then the bystander who stood to the side and did nothing or fled. Okay, so we're going to take this through an example with John. So John shows up to therapy, and John had a repeated scene in his childhood. Something happened many times in his childhood, which was that his father was very aggressive and drank a lot and would take it out on John. And often the setting for this drama was in the kitchen. And the father would get upset for whatever reason, and he would start yelling at and then beating John. The mother either wasn't in the room or left the room. So the mother is in the bystander role, the father's in the perpetrator role, John is in the victim role, and his little sister is in the room, who's a few years younger, and she's watching this happen often. And there is no savior present because nobody stopped this. It went on for years until finally John was able to get old enough to leave home. Okay, so this scene is what lives in our memory, whether we want it to live in our memory or not. And we often do not want to identify with perpetrators or bystanders, and maybe we can't imagine a savior. And so John, we're taking John as an example. Somebody could come to therapy who was any of the other roles. The mother could be in therapy, the father could be in therapy, the little sister could be in therapy, but we're talking about John today. So John contains all four of these roles within himself. They live in his nervous system through the way they interact, like this, like a play that you would go see on stage or in a movie. So the play with all four of these roles is what persists in his memory. But what John does is what many of us do. He identifies with only one of the roles. Sometimes people identify with two. So John says, I'm a victim. And this is one of the things that he came to therapy for, is that John finds himself in life being a victim. He finds himself being bullied under a great deal of pressure. He finds that his allies and supporters disappear right when he needs them most. He finds that other people watch and don't help. He finds there's not a savior present. And associated with this, he has a number of symptoms around anxiety, a lot of the normal physical and emotional symptoms that come with traumatic experiences. We're focused more on the relational symptoms that happen after trauma. So when things get intense, he may dissociate, he may lose his power, and he is susceptible to being perpetrated against. So that's John. And John right now is saying, I'm a victim, but I want to heal from this. So he comes into therapy. Okay, continuing though with what John does. When John is triggered by some circumstance, somebody could be aggressive toward him. All of a sudden, a supporter could disappear. He could just be more anxious or distressed. And what comes up in his memory is, where are the other roles in the play? Now, the reason this happens is because of empathy, basically, theory of mind. When John is in the kitchen and John is being beaten by his father, he's not in his own experience. He's trying to imagine his father's experience. He's dreaming into his father's experience, trying to imagine, what is my father feeling? What is my father thinking? Why is my father doing this to me right now? Because if I knew, then I could say or do something so he would stop. And he dreams into his mother. Why is my mom not in the kitchen right now? Where is my mom? What is she thinking? What is she feeling? If I could just figure that out, then I would know maybe what to call out or what to do so she would come in and stop my father. And he's thinking about his little sister. What is she thinking right now? What can I do to make this better for her? How could she possibly help me? So, John, this is why we store the memory of the whole scene. It's not that it's like, oh, automatically we store the memory. Our mind body is working very hard at the moment of the trauma to understand what everybody else is doing. So we create the scene while it's happening. In other words, it's happening in reality. It's happening to John and John's body. But John sees what he sees. He imagines what other people think and feel. And out of his experience comes this scene of the crime. Okay. So again, when John is now triggered, he is now looking around him using this memory and saying, who is going to attack me? Who is going to abandon me? Who is just going to stand at the side and do nothing, be upset? That's what we mean by the scene of the crime. So, what can we do about this? What it means is for us to 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 heal from this, we have to master and integrate each of the four roles. What that means is it's not enough that John simply goes through and he says, how can I make sure that this never happens to me again? And then puts those skills into his life. That's the mastery part. And it's not simply that he goes back through an exposure therapy and remembers and reassociates and completes defensive responses, reestablishes chronology, and then he says, okay, I'm good. I've integrated that part. That's not enough because when that's done, he's still got these other three roles that are floating around in his unconscious as part of this play. So he's got to do that same process with what he imagined his mother was doing and thinking and feeling, what his father was thinking and feeling, what his sister. He is each of those roles. Okay, so John goes to therapy. John has going to a good, competent, standard therapist. And that therapist says, okay, I need to create a container for John and me, so John can heal. So if you look at this oval right here, this is the therapist container, and the therapist says, in my office, there is space here for to help John get more empowered and get in touch with his inner savior, and for John to master and integrate his experience as a victim. And that's what I'm going to do with him. So the therapist creates rapport. She creates rapport with John. That's the blue line right there. And the therapist doesn't want to start with the victim part. The therapist says, I'm going to start with the savior part. And I don't want John to be stuck in this in this victim place all the time. So the therapist works with John on, what could you do to prevent this happening again? What are abilities that you could have to say no or yes in different situations, to persist? What can you do to make sure that this never happened to you again? How can you be more competent with others? So John is doing a lot of inner work with the help of the therapist to come into touch with a part of himself that can be strong, active, proactive, take care of himself. That's great. So really, really good work. So they do that work for a while until John has really integrated this part of his psyche, and he's strongly in touch with this a lot of internal agency. Great. He says, well, let's go on to step 2. And this is also included in the therapist container. The therapist says, okay, now we need to go through and do this whole mastery and integration process with you in the victim role. So we're going to make sure you had all sorts of psychological fragmentation, due to the repeated beatings. We're going to work to integrate all of that. And that's all done over time, good, strong therapy. And now John says, yeah, I get it. I was this victim and I have been victimized, but I am not fundamentally a victim. I'm this human being that this happened to, and I've got this new part where I can be a savior for myself, and I'm doing right. This is great. The therapist says, you're doing great. Everything is good so far. So then what happens is they stop. That's the problem. That's the trap. They say, now we're done, because the therapist doesn't want to include the bystander or the perpetrator role. The therapist says, no, no, no. This therapy place, it's a safe space. And in the safe space, we have saviors, good for saviors, and we have victims who are good too, and we're going to help them to get healthy and healed and strong. But we lock the door. We lock out the bystanders, the people who don't care. And we lock out the perpetrators, the people who do bad things. They have no part of our safe space here in therapy. And the clients already did that. When the client walked in the door, they only identified as the victim. So they're like, I'm victim and savior now. So they now have this agreement. They've done their work and they're done. The problem is they're not done. So John, during this process of therapy and after the therapy, it starts at this point, is John is still carrying the script. And in his script of the play, he still needs a bystander and a perpetrator. He doesn't need victims or saviors now. He's got that integrated in his psyche, but he's still going to be going out and being susceptible to or recruiting others to either attack him and abuse him or to disappear when he needs help. So this relational symptom just keeps persisting. And who does it go to? So if John is not willing to identify with the bystander inside himself or the perpetrator inside himself, who is he going to put it on? Usually their partner. So how many stories do you know? Can you think of? I've been talking a lot, so now I want you to sort of reflect on what you know about therapy and your life and your practice. How many times have you had people go to therapy? They're getting their consciousness raised, they're getting really excited, they're healing, and their therapy is going great, and their relationship is getting worse because they're realizing, oh, there are all these problems in my relationship. Oh, there was these problems with my partner. Maybe it's not their partner. Maybe it's one of their parents. Maybe it's their child. Maybe it's the world. The world is a bystander. The world is a perpetrator. So the person is only really healed within a bubble, but that bubble doesn't extend to their full life. And so this drama remains in their life. Okay. That's the situation that we want to help with. So as a therapist, let's say at this point you're looking at this and you go somewhere between interesting and horrified. You look at this and you say, okay, I want to do something about this. What can you do? Well, there's some knowledge to gain, and you maybe already have this view from the last few slides. Okay, I need to include the bystander and the perpetrator. Great. But how do I do that when I am repelled by the bystander and the perpetrator myself? And how do I do this technically? So these are the themes of the training. So let's just dig a little bit more into each one. So we've talked a little bit about the scene of the crime, but let's break this out. It's important for the client and for you as the therapist to learn about your nervous system and for them to learn about their nervous system so they can tell what state they're in, and so that when they can be in a calm, balanced place, even when they can feel their nervous system getting anxious or beginning to shut down. It's important for the therapist to be able to have a very strong emotional connection and orientation with the client and with others. And the client needs to be able to feel this also. And when we're working relationally, the therapist does not stand outside. The therapist enters into the scene of the crime with the client. So the therapist needs to be able to stay emotionally connected with themselves, as well as be regulating and co-regulating with the client and orienting to the relationship. We talked some about all those early slides were about transference, how John will tend to see people around him as a perpetrator or a bystander, and then himself as a victim or a savior. So that's transference. And as therapists, we have our own transference with our clients. And so that's countertransference. And when we're working at this technically, we're working with different memory systems. We're working with where do we habituate our memories? Where do we have our memories of distress, our anxiety and dissociation, or event or episodic memory? Where do we have our beliefs? So we learn about those things and how to work with them. Then the next part is much more, and this by far takes the most time. And we do it during the training, but this is why we have 5 months afterwards to help coach and encourage people. You got to develop your own permission space. So you've got to work on co-regulation. There's all sorts of different ways to co-regulation means to go into sync with another human being so that there is a flow back and forth between our nervous systems. And we can calm, we can excite, we can stay linked with somebody else. So how do you learn how to do that with clients when they are in certain distressed states or they talk about certain subjects that are maybe difficult for you? So you develop that capacity. Also, we've just got habits around anxiety. Some of us, when we become anxious as therapists, become caretakers and we start doing too much in therapy. Other times we get really anxious and we can create rapport with the clients very easily around the anxiety, but we're less effective. Some of us distance when there's anxiety. Some of us become aggressive when there's anxiety. So we need to know what those habits are inside ourselves and how they're triggered and how we can soften them. And then finally, we've got to return to our own trauma history. Even if we've gone through and worked all of our traumas individually, we go back and look at our relational traumas, and we've got to master and integrate all of those roles. So this is a personal growth process for the therapist to engage in that they'll be working on for many, many years. And their permission space, your permission space, will be getting bigger and with more capacity as time goes by. And then there's tools to assess nervous system states and to orient and how to teach clients how to do that. There's tools to be present in the moment and feel connection with ourselves and with others. There's just how to take a history and create a strategy to work with relational trauma, how to frame, how to say, we're going to work with this event, with this memory system, and this role. And so now we've narrowed it down to one role, one memory system, and one event. It's a very tight framing. And within that frame, of course, that enables all of this together, enables us to do relational containment. So let's say John is now working with their therapist who's now gone through this training and they've done their work and they've got a much bigger, stronger permission space. They understand the concept, they've got the tools. Now, here we've returned to therapy, and there's the therapist who isn't simply creating rapport with the client, they're actively co-regulating with the client. They've spent time so that they're much more in a flow with the client. And now notice that their permission space is much larger, and it includes the bystander and the perpetrator. And they've got a particular set of tools. And they apply these tools to do with the bystander role and then the perpetrator role, what they had already done with the savior and the victim role. So they do all of this work. And at the end of this process, now John says, oh, yeah, so I was a victim in that event, and I've mastered and integrated that. I've learned how to be a savior, and I had embedded in myself from the events to be a bystander. And I can see that now. I've worked through, with that. I've mastered and integrated that. And I hate to say it, but I have that father who beats his son. That is inside me, and I've now felt and grasped and mastered and integrated that. So now the whole scene has been integrated. And the result of that is the scene is resolved. The client is at peace. They're in balance. It's not that the memory is gone. You see it. It's in the background. It's faded in the background. It's part of their past, but it no longer drives the client's behavior. That's what you can offer your clients. So, just to recap for just a second, this talk was about relational trauma. So, I talked about we remember the scene of the event. We've got to master and integrate all four roles, and we need new knowledge, emotional capacity, and techniques to be able to do that. Now, I've talked a lot. I want to bring in and have you meet Herbert and what he's thinking and feeling about this. Herbert.
Yeah, Eric, I still love how you present this stuff. And I'm asking myself two things. One is we create this kind of permission space, which is, I think, extremely important for our work. And the other one is relational. So I was thinking, how come this along with the polyvagal theory? How does this fit into the polyvagal theory? And my answer is pretty well, because when you talk about integrating roles, it means when you integrate roles, it means you have strong boundaries, you have healthy boundaries, and this also means you can create this kind of safe space inside and outside. So this is so important.
Urso, do you want to throw him with a question for Herbert right here?
Yeah. So Herbert,
Yeah.
yeah, your experience doing the training, being part of it, leading it, what do you see as kind of the big takeaways people get from it and take away from it?
Well, it's pretty intense. Normally I know the other way around. So it's like online training, and at the end we meet each other in person. So this is the other way, and I like this, that it means we start by knowing each other and work with each other, and after this we have 5 months where we can really go into a deeper work and see how these techniques are really fitting into the relational work. So I like this format. I like the intensity of the group of people. And so we have a lot of time really to explore the different roles. So what am I identified with, and how can I work with this, and how does this reflect my nervous system, in which state I am in my nervous system. So this gives me really a deeper knowledge about where I am and what I have to do.
Hmm. Should we go back to you, Perzan, then we can open it up for a Q&A after?
Yeah, that's great. Let's do that.
That's great.
Okay, thank you, Eric and Herbert. Slide. Okay, so the in-person portion, again, it's 5 full days in person from Wednesday, October 21st to Sunday, October 25th in Denver, Colorado. And that's followed by 5 months of virtual learning. And if you're interested and want to learn more, apply, you can visit our website, traumaintegrationprotocol.com. Okay, slide. Another participant from the TIP Transference Training, Gail Neves, remarked, "The experiential aspects of the TIP Transference Training were unmatched compared to other in-person trauma-focused trainings I have attended. The demonstrations were highly informative and valuable for understanding the subtle nuances of the model. This training was life-changing for me and gives me hope for the future of trauma psychology, phase-oriented trauma treatment, and post-traumatic growth." Slide, please. Okay, and now we'd like to open it up for questions for Eric and Herbert.